Hello, everyone, and welcome to today's edition of Patcast. Today is April 7th, 2020. And at Patcast today, we are excited to welcome back Dr. Elizabeth Montgomery, who needs no introduction. So she is the professor of pathology at Johns Hopkins Hospital, Baltimore. And today she is going to discuss about iatrogenic GI tract injuries. It's some tough pills to swallow, as he titled it. Without much ado, so over to Dr. Montgomery, please. Thank you so much, Dr. Montgomery, for joining us today.
All right, thank you for welcoming me, Dr. Manan, and colleagues as well. I hope everyone will enjoy this. Today I'll be showing a whole lot of iatrogenic injury to the GI tract in the form of many slides. I'll start with something that's not exactly iatrogenic, it's simply an artifact. I noticed how many attendees are on. I see 3. Dr. Manan, what do you see? Never mind, I will continue. Okay, so
Yes.
So here we go. Here's the first thing. This is actually not an iatrogenic injury. It's just something that I learned about because I was a bit ignorant and a colleague knew. This is a biopsy of the colon. And I apologize that this slide is a bit faded, but I don't have many examples of this. And you'll notice that at higher magnification, there's this very strange red material in the tissue. And I scratched my head and I looked at every medication I could think of and wondered about all manner of diseases that this patient might have. And you see there are these just random little fibrillary crystalline things, and a very clever person, in fact, Dr. Beth Firth at the University of Pennsylvania, recognized this, and this is Eosin precipitate. And it can happen if one's eosin isn't quite in the freshest state. So a very fun thing to know about, Eosin precipitate as an artifact. Now we'll get into the real topic at hand. Let's start with something very pedestrian, very ordinary. This is an esophageal biopsy, and the colleagues noticed some strange material, and they thought the patient had terrible esophagitis. And let's have a look. And sure enough, the patient does seem to have terrible reactive changes. You see some reparative changes here in the stroma, but let's take a look at something else. So here's an area of, well, I guess we would all call it junk. And you can see that some of this junk looks like it would be polarizable. So I've taken away the condenser, turned on the light, and you can have a poor man's polarization. And you can see that there's this exogenous material. And of course, this is probably the material that's used to create a tablet or pill. Right here in the center, we have a nice mass of bacteria, not a surprise, in the esophagus. And here's something else that's kind of fun. Here's some mineralized appearing material, and this can commonly be seen in the situation of so-called pill esophagitis, or when there's pill fragments. And the name of this stuff is crospovidone, CROSPOVIDONE. And it's simply exogenous pill filler, just to, make the size of the tablet. Our colleagues in pulmonary pathology noticed it years ago in aspiration pneumonia, but we're a bit more stupid in gastrointestinal pathology and didn't figure it out until later. And in fact, my colleague Christina Arnold has written a very nice paper about the appearance of crospovidone. Let's take another look. Here's another pill esophagitis. And of course, we can see there's some dots because colleagues were a bit concerned about this reactive squamous hyperplasia or pseudoepitheliomatous hyperplasia. But there's another cute finding here. Here's some more foreign material. This is polarizable as well. And it's very, very pigmented, and it's black in color. I'm embarrassed to tell you, I'm not sure what this pigment is, but if you go and look at the various pills that can be found in the various books that have them, such as the physician's desk reference, you'll find that many of them have a lot of colorations. So I'm assuming that this is the color from one of those pills. So those are all just sort of incidental pills and not very specific, but we can now enjoy some more specific appearing pills. This is another biopsy. This one is of the stomach. You can see that it's stomach from here. This is oxyntic mucosa, in other words, with parietal and chief cells from the body of the stomach. And you can see there's this brown nonsense at the top. And let me get an arrow. Let's see. Oh, good. It shows. So you can see it at the arrow. And let's go and look at it some more here. And here's this pigment. And it's a golden brown color. And that's, of course, from iron sulfate. And this is, of course, the constituent of iron pills that people take when they are anemic. The problem with these is if you're not onto this and don't know about it, you might not notice it. Of course, in this case, it's very easy to notice it. But let's take a look at higher magnification. For whatever reason, well, for many reasons, iron is actually toxic to the epithelium. So the areas where the pill lodge have tremendous reactive epithelial changes. And if you don't notice the iron, you can be fooled into thinking that these reactive changes, such as right here, are in fact neoplastic, but they aren't. These are simply reactive. In this case, it's quite easy to see the iron, but it's not always. Let's take a look at an iron stain from the case that we just saw, because it's so cute. And here it comes. All right, so we can see there's a lot of iron in this sample. And let's look at higher magnification. What I think is kind of interesting is that the obvious deposits of iron on the surface are very easy to see on the iron stain, but please notice that there's a lot of iron that goes deeper than what we would expect, as shown here. And in fact, some of the iron is quite deep in the sample, but there's really not much way down at the bottom. Let's take a look at another case, this time of iron pill esophagitis. And this one is really dramatic. And I'm showing it to you mostly for fun because it's pretty easy to see the iron without any special stains. I'm not sure why in this case most of the iron is at the bottom. Perhaps there was an erosion and the iron undermined the tissue. But here it is, very, very dramatic in this example. And let's enjoy an iron stain from that case. And here it is. So very, very dramatic. I hope everyone is really enjoying this insane case. So we just saw iron pill esophagitis and gastritis from patients taking iron medication. As an aside, we see this in our population in about 1% of our biopsies from the esophagus and stomach. So you will see it if you have a decent volume in your hospital. What we see less often is the opposite of iron pill gastritis or esophagitis, and that's gastric siderosis. So let's take a look. This slide, for which I apologize, is a bit old and faded because we don't see it much, but it will still allow us to see the features. This is an oxyntic mucosa biopsy, and again, it has some artifact because the slide is a bit old here at the top and here at the bottom. But let's take a look at higher magnification. So ignore the sort of faded appearance at the top. Have a look at the cells in the middle, and you can see some beautiful parietal cells. I hope all of you can see them. And then as we go down deeper, notice that there's again this kind of golden brown pigment in the oxyntic mucosa that I'm indicating here. So this is gastric siderosis. In this case, it's pretty easy to spot, but sometimes it can be quite subtle. Let's take a look at the iron stain from this case. assuming I can find it. Yes. So here it is. And now we have quite the opposite situation that we had when we had iron pill gastritis. Here is the surface on the right, and down here is the deep part, and the iron has accumulated in the epithelial cells in the deep part. I'm not sure why it does. You'll notice also that it's in some histiocytes in the lamina propria, but this is the result of iron overload. And in fact, Dan Pat Jane, that's Jain, a very well-known pathologist from Yale University, years ago wrote a very nice paper about gastric siderosis. In his paper, he talked about that you can see it as a consequence of hemochromatosis, and you can be the smart pathologist making a clever diagnosis on a gastric biopsy, but more often you see it because the patient has some sort of hematologic malignancy and has been multiply transfused and therefore has iron overload. Here's another example of gastric siderosis. And again, I apologize, the slide's a little bit old. Actually, let me wipe it. Bad me. I thought I was a good girl and wiped everything in advance, but obviously I wasn't. So here's another example. And this one is pretty fun to see too. So again, you can already, even at this low power, make out a peculiar color down in the deep part of the biopsy as shown here. And in fact, this one parietal cell is really just stuffed with iron. It's really quite something. And let's enjoy the iron stain from this case. So here we go. Oh, I forgot to wipe this one as well. But I think it doesn't matter if there's a bit of dirt on the slide because we can beautifully see the iron in the deep part of the biopsy. So if you see this pattern, if you don't have the ability to check in the chart, you have to tell the colleagues to consider hemochromatosis or iron overload from something else. But obviously, if you can check the chart, please do. The next theme is a bit different. We're going to look at some medication crystals. So let's enjoy those. The first one we're going to look at is Kayexalate. And the fancy name for that is sodium polystyrene sulfonate. And it's been around for a long time. And based on the name, K, potassium, X, go out, alate, well, I'm not sure. Essentially, patients can either take this by mouth, and while it's in their stomach, this exchange resin absorbs hydrogen ions. And as the stuff goes through the bowel, the hydrogen ions are exchanged for potassium ions, and then the patients simply eliminate the excess potassium in the feces. So as you can imagine, it's given to patients who have too much potassium, and that would be patients with renal failure. Years ago in the formulations, the Kayexalate crystals were given in hypertonic sorbitol solutions. And the sorbitol solution, rather than the Kayexalate itself, caused these patients to have this horrible osmotic injury to their epithelium, and they would end up with all sorts of ischemic damage. Here we have a segment of small bowel with massive ischemic damage. The submucosa is extremely edematous. The mucosa is necrotic, and let's keep looking. And then in this one area, we can see the marker of the culprit. So the Kayexalate itself did not cause the injury. It was the hypertonic sorbitol in which it's suspended. The good news is that we almost never see this anymore. And the reason is that after a while, the people who manufactured the compound and manufactured the medication modified the formulation to reduce this horrible consequence of this osmotic injury. You still see it very occasionally in preparations with hyperosmotic sorbitol, but I haven't seen it in years in our own inpatient material. The characteristic of the Kayexalate, though, is this nice cracking that makes perfect little rectangles. And notice that the medication resin itself has this beautiful purple color. So this is a bit of a thing of the past. Now you just sort of see the crystals as innocent bystanders in non-ischemic processes. But we used to see really dramatic injury, as in this case. And this case is from, I believe, 2007. And I have not seen this problem in the last 10 years. Here's another case, also from some time ago. You can see that this is a biopsy. And most of it looks okay, but then there are these areas that are damaged. With all this hyalinization of the lamina propria, that makes sense for prior ischemic damage. And as we look, let's see, let's find a better cut. We'll find some Kayexalate crystals. So here are a few right here. And then I think there's an area with some nicer ones, but here it's in a cracked part of the slide. Let's see if I can do better. Here's another one of them. And I think there's another good area on this slide. Here. So here's another one of these Kayexalate crystals. And as I focus up and down, you can see the nice rectangular cracks. So everybody went along happily, and we thought for a long time that Kayexalate was a big deal. And then people began to look at crystals some more, and one of the people who loves to look at crystals is Christina Arnold. And she noticed that in the same patient population, there was another kind of crystal. And let me show you that. The name of that crystal is Sabella Myrrh. The trade name is Renvela. And initially, Dr. Arnold described these things, Christina Arnold, in patients who had mucosal injury and assumed that the medication may have a result. But she only initially reported a few patients, and I was on that study and I contributed. But remember, biopsies tend to be taken from areas that are injured. So we began to see this medication in injured areas. You can see in this slide, it's just a stupid adenoma in a patient who happens to be taking Sabella Myrrh or Renvela, which is the company name. And you'll notice that really there's no damage. There's simply an adenoma with the drug. It looks a bit like Kayexalate in that it's crystalline, but the crystals have two colors. They're kind of yellow with a mix of magenta, and they also differ by having kind of curvy cracks instead of perfectly rectangular cracks. Sabella Myrrh is also an exchange resin, just like Kayexalate. The difference is that its job is to get rid of excess potassium in patients who have renal failure. So you'll see these crystals in patients with renal disease. It seems that over time we've learned that they're generally not associated with injury, but you can see them in injured areas. One more thing from patients with renal failure, and that is lanthanum carbonate. Let me show you how that looks. So lanthanum carbonate, like Sabella Myrrh or Renvela, is given to patients to help them reduce their, not their potassium, their phosphate. So, this is awesome. And basically, it's just a chemical, lanthanum carbonate. It's been worldwide available for many years. In the US, we tend to like something expensive and waste money. I guess that's not very polite, but it's true. Whereas lanthanum carbonate is cheap. So let's take a look. And sometimes patients will have GI symptoms. I'm not sure if the lanthanum carbonate is what causes them. This is a small bowel biopsy, and you'll notice that the mucosa has been previously damaged because we have this gastric mucin cell metaplasia. Here's an area with a lot of eosinophils, and then here's this strange lanthanum carbonate. It has this sort of brownish color, but then you do your iron stain and it doesn't stain. You can do all sorts of fancy analysis to prove that this is lanthanum, but it's a lot easier to look at the patient's medication history, and you'll find the patient is taking lanthanum carbonate. You can see this bit of mucosa is quite damaged, So it may be that the lanthanum itself has injured it, but I don't really know. Okay, now let's look at another biopsy. I'm going to make up a history. This is a gastric biopsy from a let's make it a 23-year-old man. And he was concerned because he had severe acne, and his physician gave him some tetracycline. So let's take a look. And this is a gastric biopsy, and I've, of course, fabricated the history, but what I want to show you is actually a doxycycline-associated injury. I think a moment ago I said tetracycline, but I meant to say doxycycline. You can see similar injury with tetracycline, but it's not as dramatic. I'm just going to clean the slide a little bit. So let's take a look. So in this particular patient, there's a bit of an eroded area. And let's find that in another cut, since I've managed to smear ink everywhere. Here's that area. And the hallmark of doxycycline-associated injury can be seen here. Notice that there are these itty-bitty little capillaries in the superficial part, and they have this very, very dense, almost fibrinoid appearance in their walls, and that's very, very characteristic of doxycycline-associated injury. You can also see just prominent perivascular cuffing, but for me, the really beautiful characteristic finding is also this funny fibrinoid change in the superficial vessels. In the esophagus, you often see just very plump vessels that have inflammation kind of circling them, and you don't always get to see these beautiful areas with this funny fibrinoid appearance in the superficial capillaries. Here's some more of that stuff, and it's once you get a hint of it in this biopsy, you'll see that finding is really everywhere in the superficial vessels. Here's another one with this peculiar fibrinoid appearance. So very nice example of doxycycline-associated injury in gastric mucosa, and your history will often be an adolescent with acne hoping for some relief. Here's probably the most dramatic area in the biopsy, just to finish off with that. So, of course, there are lots of patients who have cancer in everyone's hospital. Let's take a look at some of the things we see in patients who have cancer. I'm going to show you next a beautiful example of yttrium-associated injury. And yttrium, of course, is a radioactive compound, but it's not particularly dangerous. The radiation goes less than 2 millimeters from the administered stuff. And this yttrium compound is injected into vessels generally to do chemoembolization or chemotherapy for liver metastases or even primary hepatocellular carcinomas. And it can be called transarterial chemoembolization, or TACE, T-A-C-E. And it's also called SIRS, or, oh my gosh, I'm having a moment. Well, it'll come to me in a minute. Sorry, I'm having a moment, but you can have these so-called SIRS, selective something radiation spheres, and they're yttrium compounds, but not invariably. And often the little radiation beads, when they're injected into the liver to damage metastases or primary hepatocellular carcinomas, don't go where they're supposed to. So in this case, they went into the gallbladder and resulted in an infarcted gallbladder. Here are some of these radiation beads, and sometimes you'll have the chance to see nice radiation atypia near them, not in this case. So these are these yttrium radioactive beads that are injected. The radiation is all degraded within about 10 days, and the patients do just fine with it, but sometimes there are small complications. There's a new kind of yttrium beads that is clear, and they're really hard to spot, and I'm afraid I don't have an example of one to hand to show you, but there's a beautiful paper, once again by Dr. Christina Arnold, A-R-N-O-L-D, and my colleague Lisandra Voltaggio is also on it, and I think a whole lot of other colleagues of mine, and they noticed that the beads can be clear if you want to read about the clear version of yttrium beads. This is another example. This is just a set of distal colon biopsies in a patient with a history of prostate cancer. And let's take a look. So at low power, it doesn't look like much is going on, but of course we always have to do a check at higher magnification, and we're going to do that. Oh my gracious. So what you'll notice here are some teeny little vessels right up under the surface that are running parallel to the surface. So we have this beautiful parallel arrangement of these vessels, and that's abnormal because, of course, usually the vessels in the lamina propria are really hard to see, and they run perpendicular to the surface. And this is an absolutely characteristic arrangement of vessels associated with radiation proctitis. And here we can really see nice radiation changes. And in fact, there are thrombi in these vessels. And here's one of them that's running perfectly parallel to the surface epithelium. Let's move along and see if we see some other nice stuff. So here's sort of the usual arrangement of vessels perpendicular to the surface, and we just saw all those parallel ones. And I think there's one other area worthy of sharing. Down here. Down here, you can't so much see the parallel arrangement of the vessels to the surface, although this one is parallel to the surface. But what you see is that they're quite ectatic, and these are teeny little vessels normally, and yet they have fairly thick walls. So all those things, the parallel arrangement to the surface, the thrombi, and the ectasia are great for radiation proctitis, as in this case. Let me show you another kind of fun thing that can either be iatrogenic or it can be because of prior injury to the mucosa. So let's have a fun look. So this area in the colon presented to the endoscopist as slightly nodular. And we have this cute little pocket here. Let's see if I can find it in another cut where it's easier to see without a scratch. See, if I were a good girl, I would have scanned the slides, but it's cumbersome to arrange for scanning in my institution. So here's this area that looks a little bit strange. And if we look in the submucosa, we see all these multinucleated giant cells. And let's take a look at another area. Again, we have these open spaces with multinucleated giant cells, and now we have a bunch of eosinophils. So obviously, if you saw this making little cysts through the full thickness, you'd know that there'd previously been air in there, and you'd call it pneumatosis cystoides intestinalis. But in this particular case, it's just these little submucosal nodules. So this is some sort of mucosal pneumatosis or submucosal pneumatosis. And you can see it anytime there's been injury to the mucosa. It can be from the patient, or it can be because of an overly dramatic air insufflation during the process of colonoscopy. But it's just a fun thing to see. When I see this in a child, I look hard for cytomegalovirus because you see pneumatosis anytime something damages the mucosal barrier. So now we're going to work our way into some different themes. We're going to start out with a patient who's had a bone marrow transplant. And of course, the thing we would think about if the patient has diarrhea afterwards is graft-versus-host disease. So I'm going to start working my way down the biopsy and act like I'm all smart, and then you'll see that I'm not. So I'm looking for graft-versus-host disease. Okay, so what do I want to find? I want to find lots of cryptapoptosis. So there should be there should only be one apoptotic body for every 10 to 15 crypts. So in this field, I think there's one here, and it looks like there's one here. So here's a very nice apoptotic body. The cell has fallen apart. Oh, but here's another one. So right away, I'm finding far more apoptotic bodies than should be present. Okay, fine. The patient must have graft-versus-host disease. Please notice that the lamina propria is kind of edematous, and there really aren't very many eosinophils. So hold that thought. We're down now for a few more crypts. Very easy to find apoptosis. A bit here, you can see that degenerated nucleus. There's a bit, there's a bit, there's some more, there's some more. So no problem to find apoptosis. However, remember when you look at these to always be very careful because cytomegalovirus can result in apoptosis. So I was feeling really smart in this particular part of the field, and then oops, I reached this part of the patient's biopsy, and there's obviously cytomegalovirus. So here's some beautiful cytoplasmic inclusions. There's a nice nuclear inclusion. There's another nuclear inclusion. So obviously, be careful to look for viral cytopathic effect whenever you're diagnosing graft-versus-host disease. If you're lucky enough to have immunostains, it can be nice to just do one as a precaution. Obviously, in this case, you don't really need them because the hematoxylin Eosin does the trick. Here are beautiful cytoplasmic inclusions, a nuclear inclusion, more cytoplasmic inclusions. So this was not a very difficult case to diagnose. You can see that many of the cells in this one little area have viral cytopathic effects. So it is interesting how patchy it can be. Because of that, we do encourage our colleagues to take more biopsies than they think they need to. All right, let's take a look now at the flip side. So now I'm going to look at a biopsy from a patient who's had a solid organ transplant. I apologize that this slide is a bit faded. But it is as it is. A little fairy had taken my more recent ones. And this is a mycophenolate associated injury. And it's a little bit hard to see in this slide, but I'm sure you can tell that there's been apoptotic injury to this crypt and this crypt. Let's see if we see some more recent apoptotic injury. Yes, there is. It's just hard to see because the slide has faded a bit. So here's some apoptotic injury. But what I want you to notice is that in contrast to graft-versus-host disease, this mycophenolate-associated injury has a lot of eosinophils. I mean, after all, it is a drug response. Of course, in this situation, you would also be looking for your cytomegalovirus. And if you're having trouble, you can add an immunostain if you have it. But I just want you to see that. Here's another mycophenolate-associated injury. And this is a little easier to see. It's in the small bowel. Remember that mycophenolate's trade name is Cellcept. It's given for patients who have solid organ transplants, and it inhibits the de novo pathway of purine synthesis. That pathway is very important in T and B lymphocytes. So of course it settles down the T cells so that they don't attack the new graft. Unfortunately, the GI tract also has some sensitivity and needs this pathway partly. So the GI tract, the gastrointestinal tract, is damaged. And the damage manifests as a lot of apoptosis. So here we are in the small bowel. And you can see there's a lot of apoptosis. Here's an apoptotic body here. There's the side of one there. That's probably part of one. Some of these halos are also apoptotic bodies, but the more obvious ones are pretty easy to spot. Apoptotic bodies are very uncommon. Actually, here's a very nice one. In the small bowel, you should only be able to find 1 or 2 in a pinch biopsy. If it's easy to find them, it's too many. So very prominent apoptosis. This small bowel biopsy doesn't have as much eosinophilia as we saw before. That's usually easier to spot in the colon. Let's see if this area has more. Actually, this area does have a fair number of lamina propria eosinophils. Be that as it may, sometimes nowadays, patients with bone marrow transplants are also given mycophenolate. And our colleagues may ask us to favor oh gosh, is the damage from the mycophenolate or from graft-versus-host disease? There's a poor man's way to tell, and that's to see if the patient has skin lesions, because the skin is less sensitive to mycophenolate. So if the patient has skin lesions, the patient's major problem is probably graft-versus-host disease. The other clue, however, is that if you see a lot of eosinophils, probably the main problem is that the patient is having problems with the mycophenolate. Obviously, you don't know exactly in any case, but you can guide your colleagues about working on increasing the immunosuppression or reducing the mycophenolate, and they're pretty good at titering it. All right, now we'll switch into immunotherapy. That's a bit frustrating because everything looks alike, and it all looks like graft versus host or mycophenolate injury. You just have to correlate with the clinical. So the next biopsy is from a patient with diarrhea who was taking Tremmel MMAB, which is one of the anti-CTLA-4 drugs used for immunotherapy. So of course, this medicine is given to keep your T cells from attacking your body's cells and overdoing the, basically it makes you fake autoimmune. So you can imagine that when you take these drugs, they, well, will cause a lot of apoptosis because the immune system is turned on double time and starts attacking your body's cells. So this patient was given this treatment because he had a melanoma, and you can see the same sorts of things we've seen with other injuries. So there's often a lot of apoptosis shown here and here. And then as the apoptotic cells are cleaned up by the body, then of course you start to see crypt abscesses. So here's a crypt abscess here. So your colleagues have to do stool studies to make sure there's no infection. But notice that this crypt abscess has more apoptotic bodies than neutrophils, so it suggests that it's the medication, not an infection. So unfortunately, if you get these, yes, you report the apoptosis. Here it is. Lots and lots of it. That's very good for immunotherapy-associated injury. But of course, you know, graft versus host can look the same. Mycophenolate injury can look the same. All these things have similar patterns of injury. So basically, you just see apoptotic injury with these in varying amounts. So in this particular patient, all stool studies were negative. We did a CMV stain, it was negative, and we assumed that all this apoptosis, once again shown here, reflected the tremelimumab. Here's a colon biopsy from a patient who was taking pembrolizumab, and of course that's an anti-PD-L1 drug. It looks just about the same as what I just showed you for the anti-CTLA-4 drug. You really have to know the history. In this particular example of pembrolizumab associated injury, and the trade name is Keytruda, you see a lot of intraepithelial lymphocytosis. So in a very simple way, remember that these anti-PD-L1 drugs are essentially letting our immune system go after us. So our body cells all have this PD-L1 molecule on them, and this molecule tells our T cells not to attack our body cells so that we don't have autoimmune issues. Melanomas figure out how to make fake PD-L1 and therefore evade the immune system. And so, of course, this drug blocks all of that, and then our own T cells can kill our melanomas. The trouble is that they then beat up our colons too. And so you see all this apoptosis and lymphocytosis as in this case. This particular patient had diarrhea. These patients are often given steroids for their diarrhea. And of course, they'd rather tolerate diarrhea than their melanoma. This is another patient who was taking nivolumab, which is Optive, and I apologize that this slide is a bit faded, but it's just so dramatic that I was hoping you would enjoy it. This is a small bowel biopsy. And you can see that there's massive lymphocytosis and absolutely striking apoptosis. Even on this faded slide, we can see that. Here's some, and whoops, let me focus. Here's some, and all manner of injury. This patient was administered steroids and everything was fine. Of course, when we reviewed this, we said, yes, it's probably the immunotherapy, the anti-PD-L1 therapy, but be sure to check stool studies. Now, this is the same appearance. This patient had diarrhea and one of the low-grade B-cell lymphomas, and the drug that you blame there is idelalisib. There's, guess what? Lots of apoptosis shown here and lymphocytosis. So they all look alike. You just have to dig around in the chart or write them a note, which is always frustrating. The more likely thing to cause all this damage that's more widely given to patients is olmesartan, or any of the drugs in the same class of the angiotensin receptor blockers. Losartan, olmesartan, this sartan, that sartan. And every one of them is very strange. Patients can take them for many, many years and then suddenly get this horrible condition that can look like celiac disease or like anything else. In this particular case, these are stomach biopsies. These were from the gastric body. And as you can see, there's just this horrendous destructive gastropathy. All the parietal cells are gone. It's just a horrible mess with total destruction. Lots of intraepithelial lymphocytosis, loss of parietal cells. I worked it up for autoimmune gastritis, even though it looked odd, and there was nothing to go for that. And then finally, I realized that the patient was taking olmesartan, and he healed right up. If you see an adult patient who doesn't take chemotherapy, who has any of the findings that I just showed you with all those immunotherapy drugs, don't forget about these dumb blood pressure pills. So I can only speak for my country, but olmesartan was made available by the FDA around 2000 or 2001, maybe it was 2002, but some time ago. And there are millions of people who take it. This spurious response of this enteropathy condition or gastropathy condition with it was reported by colleagues at the Mayo Clinic in 2012 who figured out the drug link. And we just see this a lot. Most people are onto it. And all you have to do is switch out their blood pressure medicine. But you can imagine lots of folks have blood pressure elevation and are going to be taking these pills. So that should be your first thought, rather than the immunotherapy. On the other hand, these are biopsies from a patient with a real disease. So these are biopsies from a little girl. And you take a look, and here we are in this small bowel, and right away, I'm seeing a lot of apoptosis. There's one, there's one. There's also a reduction in the goblet cells and lymphocytosis. Okay, so the kid probably isn't taking a blood pressure pill. What else do we have for this child? This happens to be a colon biopsy from this child. Massive lymphocytosis. And some neutrophils. And plenty of apoptotic bodies. There's one, there's one, there's one. And this is a child. So yours truly diagnosed this child with autoimmune enterocolopathy. So here's some more apoptosis in her colon. And then germline sequencing was done. So she had full genome sequencing. And sure enough, this poor little girl had a germline mutation in CTLA4. So it was as though she was born taking high doses of immunotherapy. So very, very, very sad for this little girl. All right, let's take a look at another case. This is an adult, and this is her colon biopsy. Massive apoptotic injury. And let's take a look at her small bowel, if I can find it. Oops, grab more colon. Here's her small bowel. At low power, it actually doesn't look very interesting. But those of you who are in the know already see that something's very, very wrong. So those of you, hopefully some of you have spotted it, but you'll notice that this poor woman has no goblet cells. Oh, and now let's look at the bottoms of her crypts. She has absolutely no Paneth cells. And she has a little bit of extra apoptosis. There's an apoptotic body. So this is actually autoimmune enterocolopathy, and some patients really do have autoantibodies. So don't forget that some patients really are ill. All right, let's switch gears now. This is a resection of some sort of thing. Let's see. Well, here's the thing. Where are we? Looks like we're in the stomach. Actually, did I tell the truth? Is this the stomach? I can't tell whether it's stomach. I'm embarrassed. I believe this was a stomach lesion in a background of a lot of intestinal metaplasia. And then, of course, there's this, yes, of course, it's stomach. So here's some antral type glands. And of course, there's this polypoid dysplastic lesion. If you're using the MAPS criteria, I guess you'd call it a polypoid dysplasia. If you were being a little more simplistic, you would call it an intestinal type adenoma. MAPS, of course, is the European colleagues' approach to what to do with visible dysplastic lesions in the stomach. Okay, fine. So this was a re-excision of a lesion that obviously needed to come out. We have some sort of dysplastic lesion, adenoma-like dysplasia. It's been removed. And then there's this. And this is kind of a new thing that colleagues have recognized. Again, Christina Arnold and her hench people. I think Miriam Harad-Pajou is important in this paper. And there's this stuff underneath. And of course, in the past, I have called this kind of stuff pulse granuloma, or in other words, food that's just somehow gotten into the submucosa and invoked this weird foreign body response. You might think of amyloid with all this foreign body response, but if this were amyloid, you would expect that there'd be at least some in the mucosa, and you'll just have to believe me, there isn't. And instead, this is mucosal lifting agent, and one of the trade names of it is ORISE, O-R-I-S-E, and colleagues will inject it to lift the submucosa to do an endoscopic resection, and then they go back sometime later to do a completion, and then this stuff ends up in the submucosa and invokes this foreign body response. So it's really kind of fun to see. It's really just a cutie, but the main thing is that you might mistake it for amyloid, or as I have in the past, for pulse granulomas. So kind of nice. This mucosal lifting agent, ORISE, there's a very nice paper on it that's come out quite recently, and I believe Dr. Miriam Harad-Pajou is the first author, and I believe Christina Arnold is the last author on this paper. So just to remind us, here's the real McCoy. This is an actual amyloidosis.
Dr. Anderson to Grossing.
So to me, it looks different. It doesn't have quite as brisk a foreign body response as our other stuff. You can see in the same sort of area, there really aren't a jillion giant cells. So it looks a bit different. And let's see, we won't belabor it too much. Let's see if we can find some up in the mucosa. And we may not, because I didn't bother to mark it in advance. What I mostly wanted to see is that it invokes far less brisk foreign body response. You might have a bit, but not usually in every little area. So I'll close with a little mitotic arrest. And some of my slides here are a little bit old because we don't see this much, but let's take a look at a couple of mitotic arrest cases. So as you can see, this slide's a bit faded, but it will still do the job. This is from a patient who had colchicine toxicity, and it doesn't really look like much, but these patients are quite symptomatic, and you'll see the change not near the surface, not at the bottom. You'll usually see it in the antrum, right at sort of the proliferation zone between the top and the bottom. And the hallmark is ring mitoses. So you can see a ring mitosis there. Let's go to another field. And of course, anybody can have a ring mitosis or so. Probably we all have a ring mitosis or so, but patients who are colchicine toxic have a lot of them. So in this field, there's one, and then once you spot one, you start to spot others. Here's another one. Oh, there's, whoops, I'm out of the field now. Let me go a little lower. So here's one, down here is one, and let's go to another field. So right in this field, you can see you have 1, 2 ring mitoses. So that's too many. If they're easy to find, that means something's off. The trouble is that finding ring mitoses and extra apoptosis in the proliferative compartment is not completely diagnostic. Both colchicine toxicity and taxane, which is chemotherapy, create the same appearance. So remember, colchicine does inhibit mitoses by messing up the microtubules, and it's given to patients with gout and familial Mediterranean fever and a whole host of immune diseases, even lupus. So it's really given quite widely. And it has the same appearance of injury as you see in patients who've just had taxane medications. So remember the taxanes, Taxol, which is paclitaxel, or Taxotere, which is docetaxel, are given intravenously, and then the patient is sent home, and they result in mitotic arrest right in the proliferative compartment. So the bottom will be fine, the top will be fine, and then this little band here in the proliferative compartment has the taxane effect. And you only see this for a couple of days after the patient has had the drug. So if you see this, and you obviously it doesn't take much effort to see all the ring mitoses here and apoptotic bodies. If you see this, you do have to figure out whether the patient's colchicine toxic or simply has had this taxane effect. So that was just a very nice example of a taxane effect. In that particular case, it was from Taxol or paclitaxel. I have one more taxane case to show you, and that will be the last case, and the hour will be complete. And here it is. And this is another biopsy. And this was a patient who'd had esophageal cancer. And actually, this was a consultation case, and a colleague shared it because he or she, I don't remember, was worried about dysplasia. And you can see why. But notice the surface is fine, and then down, and then let's see, let's get the base. We'll have to go somewhere else. I guess that's the base, it's fine. And then this area of the proliferation compartment, again, you see all of these ring mitoses, lots of them there. Here's one, another, and then apoptotic bodies. So that's in keeping with injury associated with taxanes. The patients don't feel anything from this. They're not ill from this aftermath of their taxanes. You just see the biopsies changes, or you see the changes like this if they happen to have GI biopsies. So it's kind of cool to see. So we've looked at a lot of stuff. Unfortunately, Dr. Menon had to skedaddle, so we won't be able to.
I'm here, Dr. Montgomery.
Unfortunately, Dr. Menon is back, but we're wrapping up. I guess he'll instruct us about how to proceed from here.
Yeah, I have quite a few questions, Dr. Montgomery, so I would be happy to pass those questions to you. So just 1 second. So one question I have is that from how should we sign out cases that look like GVHD, drug effect, etc., and we don't have a history?
Good question. I wish I knew the answer. So what I do with that is I look at the age of the patient and kind of speculate. So of course, if the patient is 70, they're likely to be taking blood pressure pills. But we have a note that says, the prominent apoptosis can be a result of blah, 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 blah. And we list all the different things and make them pick, which is really frustrating. But the good part is it makes them call you. And so then you get some history.
Right. Now, there is another question. The question is from Hazel, that can apoptosis be confused with lymphocytes infiltrating the epithelium?
Of course, apoptosis can be confused with lymphocytes. Generally, though, even darkly stained lymphocytes have a lot of internal structure to their chromatin, whereas the funny little halo apoptotic bodies don't. It's just dense, dark stuff. I mean, if you have a fancy lab, you can do caspase-3 staining to pick out apoptotic bodies, but nobody has that. Of course, you could do a T-cell stain, but I don't think most will do that. But generally, you can do pretty well just by looking at the quality or density of the chromatin.
So here's another question. What's the normal amount of apoptosis in the colon versus small bowel?
So we talked about that, but let's reinforce it. So in the colon, the normal amount is 1 apoptotic body for every 10 to 15 crypts. In the small bowel, it's more like up to 3 per 100 crypts, but everybody's too lazy to do that. A very easy way to do it is if you have a pinch biopsy, just if it's easy to find them, if it's more than 2 or 3 in a pinch biopsy, it's too many.
Right. And another question is, could immunotherapy-related mucosal injury mimic IBD?
There are papers that say but does immunotherapy injury look like IBD? And I have to say, I think the colleagues are being a little bit dramatic. I know I've even been put on one of those papers because you really don't see the degree of crypt distortion in immunotherapy associated injury that you do in inflammatory bowel disease. So in my opinion, even though there are papers about it, it's really not a problem. You just don't see much crypt distortion or, architectural distortion in immunotherapy related injury.
Right. So another question is, can we differentiate lanthanum carbonate and doxycycline injury morphologically?
Yes, we did. In doxycycline associated injury, the changes are vascular, whereas with lanthanum, you see macrophages containing this sort of pigmented material that are sitting in the lamina propria, and vessels aren't an issue.
Right. And another question is, how should we sign out these biopsies with drug-induced injuries? Should we be descriptive in a comment or note, or what's the approach?
I guess it depends on whether you know which drug. If you have a reason to know which drug, you can say iron pill esophagitis, or you can say lanthanum-associated injury, or you can say injury associated with doxycycline. If you don't know the information, of course, you must describe, and that's especially true for all the things that cause extra apoptosis.
Another question is, in case of Sabella Myrrh, is it the drug itself that causes injury, unlike with Kayexalate?
So in the case of Sabella Myrrh, I suspect that the drug doesn't cause injury, even though we reported it as such, and I was one of the authors on that initial paper. I think we just happened to see it in pre-existing injury, but nobody actually knows if there's an association with injury. If it has to do with the drug itself.
Right. I think these are most of the questions that I have. Let me just have a quick look. If those questions were all on YouTube, and I just want to check on Facebook as well if there are some more questions. Here it is. So someone says from Egypt, Kadega that I had a case of Kayexalate injury before, and it seemed that the patient has taken only one dose. Could it cause such a damage by single or few doses?
Absolutely, if it's given in hypertonic sorbitol.
Absolutely, if it's given in hypertonic sorbitol.
Right. I think those are the questions that I can see so far. I don't see anything more. Oh yeah, so here's another question. So to be clear, taxane effect vis-a-vis colchicine, are these asymptomatic changes to the gut morphology?
Yes, in general, the taxane is an effect.
Yes, in general, the taxane is an effect.
Toxicity. Of course, you could have taxane toxicity.
Of course, you could
but
have
now our
taxane
oncologists are
toxicity.
quite good with the doses.
Oncologists are quite good with the doses.
Right. And another question is, what other drugs can give increased apoptosis?
Oh my gosh, non-steroidal anti-inflammatory.
Oh my gosh, non-steroidal anti-inflammatory.
Pretty much anything.
Pretty much anything.
Right. Mm-hmm. So I think that's all we have now. And Dr. Montgomery, you would be so glad to hear that we had nearly 450 live viewers from across the world, and they defied all different time zones. And I kept account, so we have viewers from at least 30 different countries. Thank you all for joining in. So we had viewers from as far as Syria to Argentina, Algeria, India, USA, of course, Poland, and so many other places.
Well, that has to do with
So
you.
thanks a lot, everybody.
Well, that has to do with you,
So thank you, everyone, for joining in, and thank you, Dr. Montgomery, for this excellent talk. And everyone, please feel free to stay tuned for the next lecture. That's on April 10th, and we have a talk about COVID-19 testing in the laboratory. So that's on April 10th at 8 a.m. Eastern Time. Thank you so much, everyone, again.